Welcome, everybody. Again, this is room number 4, health communication and messaging. And if you see me glancing side to side, I'm trying to use one of those 2-screen systems where I'm looking at some of the information and then looking at you at the same time. So bear with me. This will be very quick with 5 minutes for presentations and then 3 minutes for comments and questions. At any point during the presentation, if you do have those questions, please put them in the chat and then we will be relaying those on. I believe Christine has the first presentation already queued up. This presenter, I believe, was Anna Bauman, and I do not believe she could be here at this time, but we have a pre-recorded version of her presentation. So we'll be starting with that.
Hi, my name is Anna Bauman, and I'm a medical student at MCW Central Wisconsin. I'm unable to be here live, but thank you for viewing my pre-recorded presentation. If anyone has any questions or would like more info about my poster, feel free to email me. I've also arranged for those monitoring the chat to forward me any questions. Just make sure you include your first and last name so I can get back to you. So I decided to work with Patch, Providers and Teens Communicating for Health. And it's a program new to Central Wisconsin based in Madison. It's a group of 10 local teens that are chosen to represent their peers and collaborate to increase awareness of teen healthcare barriers. So they encourage open discussions between peers, their parents, and their healthcare providers. So down here, this is the setup of the program. So here are the Patch teens in the middle, and there's 2 aspects. There's enrichment meetings, and then there's workshops over here. So the enrichment meetings are designed to educate the teens on certain topics, and then the workshops are when the Patch teens actually present for providers and for their peers to spread awareness of confidentiality and taking control of their healthcare, but also talking to providers about how to create the most non-judgmental environment so teens can optimize their healthcare. So basically what I decided to do is a survey that was given at the beginning, middle, and end of the Patch program. And it was only 10 minutes, and we provided them dinner when they were able to take the survey. And the template is right here. Our goal was basically just to figure out, who Patch teens talk to in the community. So although a lot of different aspects of Patch have been studied, not many have looked into their actual social network before, during, and after the program, because after all, that's what the goal of the program is for teens to reach out to their peers and help them with resources that they would otherwise not know of. So as far as the results go, it was a group of 10 teens, as I mentioned before, and I'll just briefly go through the results, the ones that were kind of interesting to me. So what I thought was interesting is when we asked in the last 3 months, what is the most common demographic you've given advice to? One teen, there were a lot of teens who said, white female high schoolers, but one person said late 40s, white female, my mom's friends. So it was kind of cool that Patch teens were actually reaching out to not their peers and actually to also their adults. So we actually are reaching a wider part of our community, which is cool. But students. So we're hoping that this will kind of help guide recruitment in the following years so we can reach a broader demographic represented in our community. So as far as, this was also a nice statistic here that teens almost doubled the number of people they gave advice to towards the end of the year. So I'm hoping that's because, they became more comfortable with the program and became more comfortable with their knowledge after enrichment meetings and were able to help peers a little bit more efficiently. Here. And then these 2 graphs were just showing, what topic their Patch teens are most comfortable with and what topic they're least comfortable with. So I was hoping, I asked this question in order to help guide future curriculum changes. So, we had enrichment meetings on all of these topics, but we wanted to make sure we were getting the information to them in an effective way. So it looks like by the end of the year, they were most comfortable with safe sex, and it looks like they were least comfortable with LGBTQ rights and gender identity. So hopefully, you know, next year we'll either be able to have a couple enrichment meetings or, you know, improve our enrichment meetings a little more so patch teens are comfortable with all of these topics that they're supposed to be. So let's see, in conclusion, we hope that after taking the survey, patch teens will be a little bit more aware of the groups they're sharing their information with, and they'll be encouraged to reach out to groups not utilizing this information. And we're also hoping that through these results, it will kind of help guide recruitment so that we're able to recruit individuals to reach all demographics and not just white females in the school district. And then also guide curriculum changes, as I mentioned before, with the enrichment meetings. So as far as the key takeaways, you know, we found that patch teens interact with, although they interact with the narrow spectrum of their population, they also interact with community members, as that one participant mentioned. And they also doubled the number of people they gave advice to by the end of the program. So I would definitely call this year's program a success, and I hope that my project helps in you know, improving the sustainability of the Patch Central Wisconsin program since it's relatively new. We're also hoping to maybe develop a similar program for adults in the future. So yeah, someone going into pediatrics, I'm passionate about adolescent healthcare and making sure every teen is comfortable in the office. So that's why I did this project, and I hope that this is a step in the right direction. Thanks.
That's terrific. And then while we still have Christine in this room, I'm actually going to ask a question about, I believe that everyone was sent a package of the presentations and the posters. And in the event that you need to blow it up or to look at it in closer detail, I believe that you can find those in the package that Christine sent out recently. All those posters are in there. So if your eyesight is similar to mine and you needed a little more detail, that would be one way that you could do that.
Exactly. Christine? Thank you, Jay. In fact, in our program, which we did send out and it was attached to the chat bar when the session began, we will also send that again to you along with the recordings of these sessions. But we also will make available the full size posters because we recognize that in the program, we were taking a poster that could have been 3 or 4 feet wide and reducing it to the size of 1 page. So some of the resolution is not going to be that great, but we wanted to have a record of it in our program. But the full size posters will be available within the next week or 2.
Terrific. Thanks very much, Christine. All right, on to our next one. By the way, what we will be doing is I'll introduce the presenter, just the first presenter, to save as much time as possible, and then I'll go over the title, and then I'll turn it right over to the next person here. So our next presenter is Katherine Quinn, and the title of this presentation is "A Gay Man and a Doctor Are Just Like a Recipe for Destruction: How Racism and Homonegativity Influence Healthcare for Young Black, Gay, and Bisexual Men."
Yes, thank you very much. So I am going to share our poster. So this is a study that I did with my colleague here at the medical college, Broderick Pearson, and then Matthew Lewis, who at the time of the study was at Diverse and Resilient, which is an LGBTQ community organization here in Milwaukee, and they particularly focus on LGBTQ people of color, particularly young people. And so Matthew and Broderick, neither of whom could present today, really did the bulk of this work. So the results that I'm going to be talking about are from some focus groups that Matthew and Broderick facilitated. I will note too that then Matthew came to the medical college to work in our inclusion clinic at Prater Hospital. So, so what we were really interested in is the disparities that we're seeing in PrEP use for HIV prevention. So PrEP is an HIV prevention pill that was FDA approved in 2012. And since then, we've seen some significant racial disparities in the use of PrEP, which are contributing to continued racial disparities in HIV. And so we've been trying to understand what some of the reasons are for these disparities and why, particularly among young Black, gay, bisexual men, they're not using PrEP. And one of the things that we're really interested in is stigma, more generally around like HIV stigma, and there's stigma around using PrEP, but also around race-based and sexuality-based stigma, so racism and homophobia to be specific. And so what we wanted to do was really look at like, how do experiences of racism and homophobia influence perceptions of PrEP and PrEP uptake among these young people who are getting HIV at very high rates, continue to do so, particularly in Milwaukee. So we did 6 focus groups here in Milwaukee with a total of 44 young people aged 16 to 25 who are Black and identified as gay or bisexual. And we asked them a lot about PrEP use, but also specifically about some of their experiences in healthcare settings to really understand how maybe challenges within healthcare settings could be contributing to this. So something to know about PrEP, it's a prescription medication. And so you do have to go in to get a prescription, but then you also have to go in for lab work every 3 months. So it does require ongoing engagement in healthcare. So it's not just like I get it 1 year and then have it for a year. And part of that is because we need to make sure we need to screen people for HIV and other STIs regularly. So that is a very important piece of this. So that's why healthcare settings are so important, because in order to be on PrEP, it requires engagement in healthcare. So as we look at the results, I'm going to zoom in just a little bit so we can see. Oh, sorry about that. Here we go. Some of the quotes. So we kind of ended up with 4 sort of overall themes that I want to talk about today, which came across in all of the groups. So the first idea was this, what one participant referred to as passive aggressive racism in healthcare settings. Most often they were referring to microaggressions is really what we would call them, sort of formally or academically. But really this idea that like, it's not this in your face racism, as this participant said, but it's sort of more sometimes procedural things like long wait times they often felt were targeted at them because of their race, but also just lack of being heard or listened to by healthcare providers. In addition to that, they really were aware of sort of the broader structural inequities that we face in Milwaukee in particular. So they talked about sort of these white communities and white gay men versus themselves and the communities that they lived in. So you can see in this excerpt, we have 2 participants in a group who are talking about sort of the white areas of Milwaukee or the surrounding suburbs, where they talk about there's more money going into those places, right? They believe that there are better healthcare providers in those communities, that they have more resources. As you'll see in sort of the second paragraph there, that participant says, he's talking about living in the hood, right? And he said, there's so much that's not going on in the hood. We don't have dentist places, we don't have hospitals, we don't have the resources that white people have. So they were fully aware of this and sort of used this as a way to say like, I don't have, it was related to sort of this idea that like, I don't have time to be caring about HIV prevention when I'm worried about, one, how am I going to get to the doctor, right? There are like transportation issues. But also if I'm worried about keeping my home or what I'm going to eat tonight, that really was a barrier too. But in addition to sort of those more race-based issues, there was a lot of experiences of homonegativity within healthcare settings. You can see in this excerpt, this participant was talking about how he had gone into the hospital or into a clinic because of hemorrhoids, and was talking about how he felt his provider treated him like he was nasty. That was his quote. And he said, how can they assume that just because I'm gay, I'm just nasty? You don't know the half of it until you're a gay man. And people echoed these experiences, including the person who responded and said, yeah, I just feel like a gay man and a doctor are just like a recipe for destruction. People felt like they weren't heard. They felt like they weren't respected by physicians. And this was particularly true when they were talking about white physicians. So we talked a little bit about some patient-provider racial concordance. So this related to some of the racial issues that I talked about earlier, but a lot of them talked about how white people, white doctors in particular, have no idea what they are experiencing or going through and don't listen or respect it. right? And so that it's not easy to go to a physician and talk to them about getting on PrEP, particularly a white provider, because they fear being mistreated because of their race or their sexuality. As a participant said toward the end, he said, yeah, they may not feel like they're judging, but you feel like you're being judged because like you're a doctor, you know, you went to this school, you make this, I make this amount of money, you know what I'm saying? I came from the dirt, right? It's different fabrics. We don't understand each other, like we can't, right? So there were really different experiences that were really recognized by these young people and referred to as reasons that they didn't want to go to the doctor to even talk about PrEP. Because remember, am I running out of time?
I just wanted to let you know, Catherine, we got about a minute left. So,
Perfect.
okay, if you can wrap it up in about a minute.
Yep. Remember that like in order to get on PrEP, right, you're also going to a doctor to say like, I believe that I'm at risk for HIV, which takes a lot of courage to even say that and talk about your sexuality and your sexual behaviors with a physician. So we need to do more work in this area, and actually we are continuing to do this research more quantitatively to really look at how interactions with providers are affecting PrEP interest and behaviors among young people. But we also need to do a lot more to improve the diversity within our healthcare settings, have more providers of color and LGBTQ providers or people who are competent in those areas. And then really think about like how we can engage trusted communities and agencies to sort of integrate healthcare into those settings so that we can better meet the needs of some of these young people. Thank you.
Outstanding. Thank you very much. Thanks for your presentation.
Yeah. Any questions?
That's also one of the things that I'm sort of keeping track of. I do have the chat on one side of my screen, and I'm looking if there are questions, I will relay those on, and I will add, I know we are getting a lot of feedback in terms of outstanding work and in terms of congratulations on doing this important work. So I'll forward that to you right now. Other questions, I will certainly relay those on, Catherine, and you'll get information. If there are additional questions, those will be passed along to you.
Great.
So,
thank you very much.
Excellent. And again, all of the presenters, I think that doing it in this fashion and having 5 minutes to present and 3 minutes for questions is a very big challenge. It's very quick to get all that information across. So I apologize if I have to hold up 2 fingers and say 2-minute warning. It's just, don't take it personally, all right? So we're gonna move on. Next presentation that I have on the list here will be done by Ryan Hillmer. And the title of this one is Anatomy-Based Community Education Using Plastinated Organs. So Ryan, it's all yours.
All right. So can everyone see the poster?
Yes.
Okay, perfect. Sorry. I often have trouble with screen sharing, so I figured I'd make sure. So I'm Ryan. I work with the anatomy teaching team in cell biology here at MCW. My mentor and I, Teresa Patitucci, we sort of worked on this project over the past year or so, looking at how we can improve anatomy-based community education through MCW campuses using these plastinated organs. So as you all know, community outreach is a big mission at MCW. It happens across all 3 campuses here in Milwaukee, up in Wausau, and at Green Bay. And these community outreach education programs are primarily driven by medical students. And they primarily are sort of targeted at high school and middle-aged students, trying to instill health wellness, number one, and then also sort of instill an interest in healthcare-related careers. So with a lot of these programs, student groups come on MCW campuses, they get this community education, and then they go back to their schools. But one thing that we thought that we could improve on is reaching out to underserved students who weren't necessarily able to make the trip to MCW. So we thought if we could provide some sort of an aspect of taking the education to the students, that might be beneficial. So regarding anatomy-based community education, currently we do have anatomical models and formalin fixed specimens at each campus. which both have pros, but they also have their cons. So the anatomical models, they really don't capture the array of anatomical variability that's present in just people in general and in real biological specimens. And they are sort of a degree removed from, interacting with an actual anatomical specimen. So they're good, but they have their cons. Also, using just straight up formalin fixed specimens, they're, main, excitable thing for students to interact with. And they do have a bunch of benefits, but they also have drawbacks in that, they're fixed in formalin. So they do have an odor to them. They can be irritating to respiratory systems and to the eyes, and they need to be handled in a well-ventilated environment. So usually when we're using these specimens, students do need to come onto campus for these education programs. So we thought that if we could sort of keep the biological significance of a formalin fixed specimen, but sort of transfer it into an inert, movable system that we can then take off campus, that would be best. So we sought to take advantage of plastination, which is a method of taking biological tissue and making it into an inert, odorless, non-toxic specimen that was initially developed by Günther von Hagens and in previous years sort of popularized by the Body Worlds exhibits. And so what this process entitles is it entitles initially, harvesting your organ or your tissue that you are interested in teaching about, fixing it in formalin, then rinsing it in water, and then dehydrating it in an acetone bath. And that the organ can essentially sit in an acetone bath for anywhere from 2 days to a week until you get a reading of about 98% purity in the bath. So once it is dehydrated with the acetone, then it's infused with the polymer, which essentially replaces any of the biological tissue with this sort of plastic polymerized tissue once the curing process is done. So once it's infused with the polymer, you can cure. And then after about a few days of curing, you essentially generate a non-toxic, odorless specimen that can then be handled freely. You don't need to handle these with gloves. There's no ventilation requirements. They're just easier to handle and easier to utilize in community education. So what we did was, for this project, we plastinated 3 human hearts, brains, and kidneys from bodies that are part of our anatomic gift registry here at the Medical College of Wisconsin. So we took out 3 hearts, brains, kidneys, we plastinated them, and we put them together as kits for each of Milwaukee's campuses. So we've sent one to Green Bay, one to Wausau, and then there's one here at Milwaukee. So these kits contain these plastinated organs, and you can see here in A, this is a plastinated heart. You can see that it does retain a lot of its anatomical structure. So you've got your atria up here, your ventricles, your aorta, your pulmonary trunk. You can even see some vascular down here, the LAD. You can see the coronary sinus along the posterior surface of the heart. So these are structures that are maintained throughout the plastination process. So each kit contains the organs. It also contains some stickers because these are geared towards a younger group of students. So they get some stickers to sort of take home as a sort of memorabilia from going to this education event. And then it comes with this sort of a pamphlet with information about each organ. So it's got relevant anatomical information about heart, kidney, and brain. It has brief information about plastination, and then it has a QR code which can link the students out to take a survey of how they enjoyed the community education session, how they enjoyed working with the plastinates, did they feel that the plastinates were, a useful educational tool, those types of things. And so here you can see this is one of our MCW anatomists who was able to take this kit off campus and interact with schools at a local elementary school and sort of show them the anatomy at their own, school. They didn't need to come to MCW to do this. And what's cool about this specimen, you probably can't see in the zoomed out view, but she's showing them a heart and it does have pacemaker leads. So on top of showing them just general anatomy, we can also plastinate specific organs that have more, clinical implications to show the students what this looks like. So far, these programs that have been taking place at all 3 of the MCW campuses have reached about 440 students. And although we do have surveys that the students can link out to take sort of satisfaction surveys and how they enjoyed interacting with the plastinates, our sort of response rate has been very, very low. I think we've only gotten about 5 of these back. So one of the things we're looking to implement in the future is to, instead of have a QR code survey, just have a direct pen and paper survey after these educational events that students can take sort of in person right after they're exposed to the plastinates. And hopefully that can boost our survey results. However, despite the sort of student feedback being relatively low, facilitators have commented that these plastinates do seem to serve an important and useful function in anatomy education. The students seem to enjoy interacting with them. I've participated in a few community education programs here on campus. The students always get super excited about anatomy. So this is just one more facet or one more way that we can really introduce students into the health sciences, getting them excited about anatomy, getting them excited about healthcare, and just sort of sparking some interest, hopefully, for potentially future career choices. So in conclusion, we were able to bring plastination on campus, use it for these programs, make these kits that we can then share with the community. And although response rates have been low, they do seem to be a helpful tool in community outreach.
Thank you, Ryan, very much. I think that the work that you and Teresa are doing and follow-up surveys that you'll come up with is going to be very interesting to see if you can collect more data from that. That'll be wonderful. So
yeah, definitely.
Excellent, outstanding work. We're going to go ahead and I'll have you just click out of sharing that screen, and we're moving right along. The next presenter is Maren Hawkins, and the next presentation title is COVID-19 in Wisconsin, a qualitative study examining Wisconsinites' perceptions and reactions.
Thank you so much. So yes, my name is Maren Hawkins. I'm a PhD student at the University of Wisconsin-Milwaukee Joseph J. Zilber School of Public Health. So we've all been living through COVID-19, and we recall back in March of this year, Governor Evers started the COVID Safer at Home order. We were all pretty locked down. So the research team sought to capture Wisconsinites' experiences very early in the pandemic. And our goal was to examine Wisconsinites' perceptions of and reactions to COVID-19 during the Safer at Home order and immediately after its end, using a community engaged, inductive, qualitative approach. So we got IRB for this, and we did semi-structured interviews. So as you can probably imagine, it was a little bit difficult to do recruitment with everything shut down. We used a purposive snowball sampling approach, but since everything was shut down, or the businesses that were open were pretty overrun, such as healthcare facilities, or were trying to adapt, it took a lot of work to get responses. So we worked really heavily with community stakeholders, both in terms of reaching out to people, but also in establishing trust. So some participants would not speak with us until after they had spoken with their community leader to ensure the trustworthiness of us and our study and how the data was going to be used. And then consent was a process. So obviously, because of COVID, this only required verbal consent. However, we sent all participants a copy of the consent form ahead of time to review, average of 24 hours. We then covered that verbally to address any questions. And this was to allow enough time that people could really think about what they were signing up for. And then our semi-structured interview guide was built based off of Ade and Cornelius's and Blair's recommendations for interview guide creation. There was a total of 20 questions, and our interview guide was divided into 2 sections. So one section focused more heavily on COVID-19 when we asked questions such as describe a typical day in self-quarantine. And the second section of our interview was when we shifted the focus to COVID-19 in the context of public health. So we asked questions such as, what did you think about public health before COVID-19? Again, all interviews were done over the phone, recorded using recording software, so Yeti and Personas. And then we used Otter AI to transcribe it. And then I verified the translations. So we did a total of 25 interviews. And then, as I mentioned before, we used a thematic inductive analysis approach. So I made this nice little chart. I'm going to try and zoom in. Oh, I can get over there. So this is our snowball sampling referral chart. So you can kind of see, based on who we reached out to, how many people they referred us to in their networks. Can everyone see the snowball sampling referral chart okay?
Yes.
Okay. Perfect. I'm going to scroll back up. So all of our participants resided in southeastern Wisconsin, and 79% of the participants resided in Milwaukee County. We had a pretty, it went really well working with the community stakeholders and community leaders. And then our research team has all lived in Milwaukee for several decades. So we were all pretty integrated and had strong community connections before this. So we built on those, and it was quite successful in terms of recruiting, even though it was extremely challenging. So 36% of our sample was white, 20% was Black, 16% was Southeast Asian, 8% was Central Asian, 8% was Latinx, 12% were biracial, and we had about a 50-50 gender split. And then our participants ranged in age from 22 to 68 years old. And so our initial findings, we had 4 main results, and those were the role of, or 4 main themes, the role of COVID-19 in exacerbating health inequities. Number 2 was following the safer at home order due to a sense of societal obligation. And 3 was the changing impressions of public health. And finally, 4 was the adverse impact of COVID-19 on mental health. So I put a lot of participant quotes here, but that's really to kind of center their voices so you can really hear what they were thinking. And again, the snowball approach was extremely advantageous to sampling because we really reached people that we would not have otherwise. So for the first theme, participant 5 said, so many people in the health department now have to focus on COVID. They realize that all of these children that were spending, 6 hours a day at school, from most likely the biggest place where they would get lead poisoning, are now back in their homes and potentially being lead poisoned. So it's like this double-edged sword. There's these issues, these issues are just piling on top of each other. But it's also that it's not been taken care of in the past until now. There's just this kind of, like it's piling up on top of each other, layers of issues that they have to work through. And then regarding theme 2, so following the safer at home order, participants 12 said, to live in a society is to help each other. And participant 4 said, I think we need to be self-correcting whether we have it or not. Let's really be serious about this. A lot of people may see things differently, but we can have a strong economy, but people are getting sicker and sicker. So it doesn't help you in the long run. We should be willing to sacrifice a little bit for the long future. And then moving into the third theme, so changing impressions of public health, participant 1 said, I think that in the world of public health, yes, the AIDS epidemic, lead poisoning in Milwaukee, those are things that might be kind of on the outskirts of your life. You've heard about it, but never been fully immersed in it. There's no avoiding public health right now for the general population. And then finally, regarding the fourth theme, participant 17 said, sometimes I just use a piece of paper, like what I need to get done for today. And I just try to stay focused as much as I can. And then now what I've actually started like 3 days ago of like setting a cutoff time of like, I don't know, let's say 9 o'clock. And then I can read and like meditate and start trying to heal in a sense, but prior to that, I was just all over the place. And finally, participant 23 said, man, this is heavy. It's almost depressing to be stuck inside and not have that typical, enjoyment of going out to a restaurant or maybe a concert or something like that, or a sporting event to look forward to. And so there's that aspect of it that I think mentally weighs on people, and that's been kind of tough. So those were our initial findings. And as we've really gone more in depth in looking through our findings, we've started to develop a thematic diagram. So that's, you zoom in. for kind of how all of these issues and themes are layered on top of each other, and then the key concepts within them. So the structures driving these multiple inequities are at the top, with kind of the social responsibility, healthcare, public health in the middle, and then on the bottom, obviously, are the individual things. So routine, control over exposure, and control over information. And our present conclusions are that understanding how Wisconsinites reacted to and really thought about COVID-19 can help inform future policy and future pandemic responses, as well as just get a more robust sense of how people really felt about things like the safer at home order. Thank you.
Excellent. Thank you very much, Maren. If I have a quick question for you in terms of the timeline on your data collection and your interviews, were those 25 interviews conducted early on during when the after March, or what was the time frame for some of those interviews?
March 30th to early June. I don't remember the stop date, but it was a pretty short window because we were trying to hit the safer at home order, and then we just kind of had a few stragglers after the safer at home order ended.
Yeah, and again, there's a comment in the chat that says it would be very interesting to see how your thematic, your themes emerged, and if those are still current, and doing some follow-up work would just be amazing and great to find out if those are still the themes that are emerging.
Yes, I completely agree.
Yeah.
Because this was pretty early on. It'd be interesting to see how people stayed the same or changed.
Yeah, well, thank you very much for your important work on that. Next one. There are some additional questions, and I know those will be passed right along to the presenter, so I apologize in advance if we don't get to all of those questions. Those will be forwarded, and hopefully you'll have some email communication back and forth as needed to get those answered. Next one, Thomas Luo, I think, I apologize there, Tom. Implementation of digital strategy for community-based COVID-19 clinical trial recruitment. Whenever you're ready.
Oh, okay, let's put this person. Yeah, hi, so I'm Thomas. I'm a medical student, second year at MCW Milwaukee. So just to start off, yeah, clinical trial recruitment is really difficult even in non-COVID times. So like 2/3 of clinical trials never meet their full enrollment goals. And so a lot of factors have been identified as to why that is. Some of them include socioeconomic status, a really valid mistrust in the medical system, or like not being near a large academic medical center. And so these factors have also precipitated disparity. And so just to point out one of them, African Americans are at a 5.7 times greater risk of dying from COVID-19 in Wisconsin, but they make up only about 20% of major clinical trial cohorts. So that was the Gilead remdesivir trial. As trials are like the basic tool we have right now for COVID-19 treatments, we need to engage the community. And so although most patients will match with clinical trials through their provider, there are a number of online tools that have been developed for the purpose of matching patients with clinical trials. And so we did a little bit of a analysis on these, and we found that either they were too research oriented with complex language, or they collected a lot of information that was either HIPAA or creating accounts and things like that. So we wanted to create an anonymous web-based search tool so that patients could discover clinical trials and then enroll themselves. And so we had 3 basic pillars. We wanted to provide the easiest search function possible. We wanted to have an education component because not everyone knows about clinical trials. And then we wanted patients to be able to connect themselves without going to their provider. And so we had 3 basic phases. The first phase, we sort of talked to a lot of physicians at Freighter and other places about what sorts of information that patients really need to make informed decisions about enrolling in trials. And then we went to clinicaltrials.gov, which is the government database where all information about clinical trials is stored. And we pulled a lot of the pertinent information from there, and we distilled it in a way that there was no jargon and only the critical information was there. and we launched a simple search website via social media, and then we subsequently launched education pages about convalescent plasma and vaccine development, as those kind of became more important during the pandemic. And so we have an example page here. Just to take you through it, we had an abridged title at the top, and then we did a little summary paragraph about what the purpose of the trial was for, whether or not you would receive placebo, and whether or not there was any previously published safety data. And then we also made sure to really define where the trial was located and whether or not you had to come in multiple times for follow-up or you could do it remotely. And safety was one of the big things we figured out that was most pressing in patients' minds. So we linked and described directly from either the FDA labeling if the drug had previously been approved, or like earlier phase clinical trial or other clinical trials tangential to the one that they're currently interested in. And we also did a little bit of simplifying of the inclusion-exclusion criteria to only include the major ones or ones that patients would actually know about. And so we launched on social media during the first wave of the pandemic, and we had a lot of interest. Pages about plasma donation and hydroxychloroquine got a lot of views. But you know, it was sort of difficult to find really engaged users, and we had users only click on a few pages at a time. And so we're really looking to find a community partner that would be able to create a more engaged user base. And so to conclude, a digital tool for clinical trial recruitment could really bridge a lot of these disparities. But we struggled to track that because of our anonymous platform. We don't want to collect a lot of information, and we identified that as one of the two pillars needed to create the ideal clinical trial tool, the other one being ease of use. And so we're looking for new ways to investigate that. And also I want to thank Brian Zhu, he's a software engineer at Airbnb, who helped us launch the website.
Outstanding. Thanks, Thomas, very much. Comments here are, well, I have a quick one for you, Thomas, about, do you feel that clinical trials are equally impacted? In other words, are people responding similarly to clinical trials for COVID-19 versus all other types of clinical trials? Does the tools that you're talking about differentiate in any way there?
Yeah, so I think because of the national attention and a lot of political attention, I think there's been a lot more interest in these COVID-19 trials. And so patients are more like motivated, and especially if they've heard a lot of things about COVID, they're more likely to enroll than if it was for a less, either an observational or less, serious disease. And there's more of an like patient motivation as opposed to some of these other trials where it's oncology based, where things are hard to like conceptualize, and you need an oncologist to like explain things to you or identify your tumor type, things like that, which don't really apply to these like vaccine and plasma based trials.
Right. And I wonder if conversely those other trials are being impacted negatively.
I believe so, but I'm not sure to what extent.
Okay. Fantastic. I'm looking in the chat, and I'm looking, there are, again, a few compliments on your presentation, and particularly about your excellent timing. At the moment, I don't have any other questions that are in there, Thomas. So again, thank you very much for your presentation. And I'll go ahead and have you unshare your screen, and we'll move right along. All right, our next presenter is Jonathan Horng, and the title of this presentation coming up is Mask Up Milwaukee, the Medical College of Wisconsin's Collaborative Response to the COVID-19 Pandemic in Greater Milwaukee. So Jonathan, when you're ready. You want to?
All right, so obviously I was muted. Okay, so hi everyone, I'm John Horn, and I did a project called Mask Up Milwaukee, the Medical College of Wisconsin's Collaborative Response to the COVID-19 Pandemic. I did this with Michelle Horn, Mac Jablonski, Dr. Franco, Dr. Callett, and Dr. Chris Davis. As we are all aware, an outbreak of COVID-19 really changed our world back in March, and it was declared a pandemic and a national emergency. And the virus was transmitted from person to person through respiratory droplet exposure. And infected individuals can spread the virus even when asymptomatic, leading to a shortage of personal protective equipment for healthcare workers. And the CDC had recommended for the general population to wear face masks in public to help prevent the spread of COVID-19. And at the time, it was just clear that the current supply was not going to be sufficient. So Rebel Converting, a medical supply producer of hospital disinfectant wipes, donated the raw materials to make 1 million face masks. Early volunteer mask assembly and mask distribution efforts were facilitated through the collaboration of the trauma surgeon, Dr. Chris Davis, a small group of students from the Medical College of Wisconsin, as well as faculty and staff from the Kern Institute. And here we have a picture of Michelle delivering a box of masks to Ayuda Matua in Milwaukee. At the beginning of the project, the Kern Institute staff and faculty organized and facilitated the receipt of mask kit shipments from Rebel Converting, mask kit pickups by MCW volunteers, as well as the deliveries of assembled masks to community organizations. Additionally, in-house assembly of masks was performed by volunteers in the Alumni Center. We just want to give a lot of thanks to Joan Weiss for a lot of late nights of coordination and figuring out details for us early on. And here we have a few more pictures from our volunteers. Early on, boxes of assembled masks were delivered primarily to community health centers and nonprofit organizations serving disadvantaged populations. Unloading assembly kits that we got from Rebel Converting was definitely a challenge. We would typically get about 100 boxes per delivery, and within each box there was enough materials to make about 700 masks. And at the beginning of this project, we had volunteers call organizations that could potentially serve as distribution centers. Here we have pictures of delivery to Rogers Behavioral Health Center, Isaac Cogg's Federally Qualified Health Center, United Migrant Opportunity Services, also known as UMAS, as well as Sherman Park Neighborhood Association. Some other organizations that we delivered to that are not shown here are the Correctional Facility, Milwaukee Police Department, the homeless shelter, food pantries, MPS feeding sites, churches, the grocery union, as well as Milwaukee Public Transit. So Mask in Milwaukee was a local crisis intervention initiative that was really made possible through the partnership of Rebel Converting, local nonprofits, and MCW. In the early months of COVID-19, the project utilized a grassroots public health approach with what resources and manpower could be found. And a three-pronged approach included mobilizing volunteers through multiple media outlets and as well as using volunteers to assemble masks and prioritizing the distribution of masks to the underserved and high-risk populations. So here's a timeline of how our project progressed. So on April 3rd, mask production began. In 1 week, volunteers constructed and delivered 33,800 masks to community health centers and vulnerable populations. And this early success prompted Rebel Converting to increase their donation to 3.5 million masks in conjunction with private-public partnerships, including the Milwaukee Bucks and United Way. And by the end of the first month, over 600,000 masks were distributed. In the following month, that number increased to 2.1 million masks sent to more than 500 social service agencies in Southeast Wisconsin. And currently the project has delivered 3.2 million masks and counting. So in conclusion, Mask in Milwaukee was a grassroots public health initiative that leveraged strategic partnerships, community engagement, and social messaging, as well as volunteer efforts to provide masks to the Milwaukee community. And this project demonstrates the influence that a physician can have as a leader in the community. Furthermore, this provided unique firsthand opportunities for medical students to influence their community swiftly and methodically in the face of a crisis. This experience highlights the importance of educating future healthcare professionals on the basic principles of public health, community engagement, and advocacy, which is currently lacking in our curriculum. In terms of future directions for this project, we're preparing manuscripts to detail our response to the COVID-19 pandemic through Mask in Milwaukee, as well as developing an educational curriculum for medical that lots of people to acknowledge that were involved in this project as well as organizations that we had partnered with. Thank you for listening, and I'm happy to take any questions.
Thanks, John. Very, very nice. I'm waiting for them to populate into the chat, but of course I've got a few questions. I think that's why they have me here, maybe. If, as you look back over the progress of this initiative, are there things that you could say this was critical? What was perhaps one or two of the most critical things that occurred that really made a big difference?
Yeah, I think we were very fortunate to have Dr. Franco, kind of who's had a lot of experience with, like, you know, community engagement to guide us in the beginning. At the beginning of this pandemic, a lot of us didn't know, you know, to what extent this virus was going to impact our economy and the health of our communities. And, you know, there's a lot of questions about where should we be delivering these masks to? And I think one thing he mentioned, just a principle, was to, you know, to basically just assess where you think the biggest needs are based upon your best research, and to make a move. Because if you sort of hem and haw and just kind of persevere over it, you might not be able to make as big of a difference in the community as you would have liked. So there's sort of this like balance of between being thoughtful and methodical about what you're doing, but also, of course, at some point you just have to make a move. And I think because we were able to do that, we were able to make quite a few deliveries within like even a week.
Yeah. And I think, have you been able to reach out to any other parts of the country, for example, New York or Los Angeles or other, you know, Chicago even, and figure out in what ways do their methods compare to what your group was able to do? Have you looked at comparisons?
I haven't yet, but that would be really interesting, because I think collectively, ideally, you can sort of form like a broader discussion about how we can respond to future crises like this in the future. Obviously, Katrina had happened, and you know, I think there will be surprises in the future as well. So it's important to know how to respond.
Yeah, absolutely. All right, thanks very much, John. I know that any other questions that come up in the chat will be forwarded on to you. So great job, and appreciate you presenting. All right, and I believe I'm going to double check. I think Christine may still be there, but what we have next is sort of a 2-for-1. And what we have is a study with 2 parts. And the first part, I believe, will be Corina Norrbom. Corina, I hope I did okay with your last name.
Yes.
And the title on this one is COVID-19, Engaging Hmong and Hispanic Populations in Bidirectional Communications. So Corina, you're doing the first part, and then
Yes.
Dima may be doing the second part, correct?
Correct.
Excellent. So we'll have you go ahead, Corina, and share your screen with us.
Okay. Okay, can everybody see it? Okay. So again, my name is Corina Norrbom, and I'm a family physician, and I co-direct the Physician in the Community course up at MCW Central Wisconsin. This is the first of 2 posters that will be presented about COVID-19 Hmong and Hispanic Bidirectional Communication Project, and it's a partnership between the Wisconsin Institute for Public Policy and Service and MCW and many collaborating organizations. I'll talk about the background and the shared model for the project and present Hispanic community results. And Greta and Dima will be presenting a poster with Hmong community results, as well as conclusions and future directions. And we'll bank our question and answer time until the end, if that's okay. So basically, you know, people do not think of Central Wisconsin as being a diverse place, but as it turns out, we have the most dense Hmong population in the country. And also we have a growing Hispanic population, particularly in rural Central Wisconsin. And an informed public plays an important role in the setting of a pandemic, and basically immigrant populations are particularly vulnerable to negative health, educational, and economic impacts of COVID-19. And with COVID-19, people need to have access to information about preventing and mitigating the spread of the virus, but they also need to have access to resources to be able to help keep themselves and others safe. And it was noticed that communication between public health, health systems, resource agencies, and the Hmong and Hispanic communities was in general suboptimal. And so our project, we wanted to take an innovative approach to strengthen the communication between public health, health systems, and resource agencies and the Hmong and Hispanic communities. So if you'll notice, community is on top of our model, and basically intentional listening is paramount to the project. We want to know, what do you know about COVID? What information do you need? Where do you get your information? Who do you trust? What resources are lacking? And basically, the project team hired Hmong community coordinator and Hispanic community coordinators. And basically these coordinators recruited community liaisons or community health workers. And the community liaisons are the eyes, ears, and mouth for the community. And the community coordinators are the conduits in terms of the information between community and the group on the bottom, which, like a lot of, again, health organizations, the health department, and resource agencies. So the project team was busy collating and continues to collate information, not only from the folks on the bottom of the model, but from other entities across the state and country even. And basically, the coordinators meet with the liaisons every 1 to 2 weeks. And as far as gathering information, it's through note-taking about stories. The liaisons also do input information to a Qualtrics tool after interactions with people as well. We did find in the Hispanic community that there was some difficulty with literacy, and we oftentimes had to have verbal exchange of information. The community coordinators then in turn meet every 2 weeks with the group of community collaborators, because as you know, with COVID, information has been changing and there might be different recommendations. There may be new resources available. And so it's really important to have this communication going back and forth. So we know that there are barriers and we continue to learn. I'll just highlight a couple. Language and literacy, basically in the Hispanic community, after doing a survey of a number of farm workers, basically there were 81 adults surveyed. It turns out that their average educational achievement was 6th grade. And so you have to be, really thinking whether written information is going to be helpful. Is it better to be verbal? Is it better to be presented via videos? So we're constantly learning about how to get information out. We know that there are definitely cultural differences. We know that immigration and fear of the public charge rule is very real. In the Hispanic communities, we also know that housing and employment are often linked. And so if a person is told to quarantine, if they fear that they lose their job, they may also fear homelessness. And so there are just many different aspects that go beyond, what we might think. And these observations that we've had, like in terms of through storytelling, the qualitative information and some quantitative information, is just the importance of a trusted source of information as far as that delivery. And also in the Hispanic community, finding, like people where they are, it might be through a food distribution, it might be going out to the farms themselves, to a grocery store. The mobile Mexican consulate had made a visit and we connected with over 100 families there. We also know that we need to use the platforms that they're using to gain information. The group was very helpful to the health department in terms of helping with building trust so that they would even answer the phone for contact tracing. And there's a cultural hesitancy to ask for help. So and we know that there are a lot of times resources available, but just that complexity of attaching, of getting the resources to the places where they're needed. And it was emphasized a lot that personal communication is really important. So some of the impacts of the project are that, we have been getting information out about COVID-19 as far as prevention and mitigation strategies, but we found that it needs to be in different formats: verbal, video, infographics. We've been trying to take in as much information as we can as far as to get a better understanding about their knowledge, behaviors, fears, attitudes, challenges that the communities are facing. We've delivered lots of groceries to quarantine families through our connections with the health department. We've been able to get masks and hand sanitizer out. We've been able to help families find resources through, for instance, a UMOS grant that is available to families regardless of their status. It's a real challenge. We worked with United Way of Wisconsin, think about 211. But if 211 operators connect people with a service that requires a social security number, that's not terribly helpful. So basically, we've been Marathon County and some surrounding communities. So I'll pass it over to Greta and Dima.
Perfect. Thanks very much. Thank you.
All right, thank you, Dr. Norrbom. Hi, everyone. My name is Greta. I am a second-year medical student at the Medical College of Wisconsin, Central Wisconsin campus, and I'm here with my classmate Dima, who will be presenting the second portion of the Hmong data. And so we are now going to share how that same model of bidirectional communication, data collection, and community outreach played out when reaching the Hmong populations in central Wisconsin. And so the backgrounds and methods to this project was essentially the same as what Dr. Norrbom has just walked us through. A team was established that included Hmong community coordinators and community health workers, as well as representation from local organizations. And so the Hmong health workers served as liaisons, meeting with community members to distribute surveys, collect data, and assist with COVID-19 education. One significant difference from the Hispanic outreach project was that Hmong liaisons chosen were already integrated into community organizations that were frequently used by community members already. And so by utilizing these existing connections, we were able to collect more survey and more voices. The survey data that was collected was then brought back to the established team to be analyzed and shared with relevant groups such as the health department. And now to briefly walk through the most significant results from the collected surveys. And with this outreach, we really wanted to know what concerns the Hmong populations held regarding COVID, where they were receiving their information about COVID, and what resources they might be in need of. And so if you look to figure 1, it shows that the majority of survey respondents were either extremely worried or very worried about either themselves or their family members getting COVID. So there is quite a great deal of fear surrounding COVID within the community. Figure 2 then highlights the most common impacts COVID has had on these communities. Of note were the social and economic impacts. Social gatherings, especially with extended family, are so central to Hmong culture. And so many survey respondents commented on how difficult this time has been for family. And we also heard again and again about the financial burdens and hardships experienced during this time. And with any qualitative data, sometimes the most impactful pieces are statements. And so we've highlighted 2 quotes in the light green boxes under the qualitative data box. Both quotes highlight the economic hardships mentioned, as well as concern and worry for family. And I'll just read one to you now. Money is starting to increasingly become an effect with bills rising. My family's well-being is always on my mind, and it's becoming increasingly more difficult to keep myself updated on what's going on in today's society. And so we found that while the majority of respondents understand what COVID is, there's still a lot of confusion that exists around the proper safety protocols and what to do if experiencing symptoms. Also very important were the responses to the questions asking what types of resources would help you right now. And we saw a lot of responses highlighting again the economic hardships of this time for the community, responses such as food and rent assistance, education help, food share funds, internet at home, and mental health resources. And finally, some lessons we plan to take with us moving forward, just that the importance in this type of outreach to use trusted resource or trusted sources. So the Hmong liaisons have been so central in the success of this project. Many respondents commented again on the difficulty of accessing resources. And we also learned the value in utilizing videos in our education. Dima will now take you through the discussion.
All right, so don't know if hopefully you can all see me, but so from the survey responses that Greta just went through, we noticed that a few of the major concerns that stood out were regarding financial support. Many people were worried about paying their bills and feeding their families. So in response to this, our community liaisons worked on helping people apply for financial assistance programs. They were also able to help secure grants for many Hmong families through UMOS, which Dr. Norrbom mentioned allows people to give grants to those who are undocumented. And they were also able to set up grocery store vouchers with Hmong businesses to allow families to buy groceries while also supporting those small Hmong businesses. And so on this poster, you can see some pictures of food boxes that were distributed by the Hmong American Center, where we had a pretty large turnout. And so our survey responses also indicated that many people did not understand what COVID was or the proper procedures for it. Liaisons responded to this by educating the Hmong community on procedures for hand washing, social distancing, and where to find testing sites around them. And so they were also able to distribute hand sanitizers and masks. And one of the most important things to make note of for this project is that when COVID first hit, the health department really didn't have any connections to the Hmong community and didn't know how to send information to them. But through the liaisons, we were able to build a relationship between the Hmong community and health department that was previously absent. And so with this new relationship, the Hmong community and health department even worked together to make guidelines for funerals, which was identified as a super spreader for COVID. And so this is just one example of how that relationship is going to be helpful moving forward. And so for our future directions, we just received an influenza community outreach grant from the Wisconsin Department of Health. And the goal of this grant is to try and connect the Hmong and Hispanic population to affordable vaccines. And we're hoping that by getting more people vaccinated, we can avoid future hospital admissions for influenza, which is important since our hospitals are currently at full capacity with COVID. And so we have some other programs too, where we're working on aiming to connect the Hmong population with health insurance and primary care doctors. And we're also working on setting up Zoom calls where people are able to ask general health information. And so that concludes our presentation. Thank you for listening. Sorry, I think that went a little bit over the time, but thank you.
No, to be honest, your timing is actually quite good, and we still have about 4 minutes for questions, so that's perfect. There is a comment in the chat that says that it's an outstanding example of true community engagement. And I would echo the idea that this bi-directional communication is a fantastic model, and I wish you all the best as you continue to work with that. I do have a question. Again, I'm trying not to monopolize the chat. If there was something else in the chat, you wouldn't have to take my comment. But the question that I have for you is, how can this be transferred to other Hispanic communities or other Hmong populations across the state so that it sounds to me like these community liaisons were critical. And how is it that obviously you had to do some excellent work to find those people and to be able to have them become part of it? How can other communities do the same thing?
Well, I mean, We do think about, like policy as part of this too, in terms of, I mean, it really was a grassroots, like an idea that happened at the end of March that just has kind of continued, and we've cobbled together funding to keep it going because the liaisons and the coordinators really feel strongly about continuing. And by getting this Department of Health Services grant, I think it'll give us the opportunity to expand enough to think about how do community health worker networks, like if they are impactful, which, like anecdotally and with bits of data that we have, it sure seems to be something that's effective. How could we get it to be something where these community health workers are, like part and parcel to communities? Because there's definitely a need for improving communication, not just with Hmong and Hispanic communities, but just in general. But like it's just been illustrated with these communities up here with challenges with communication.
Right. And I would wonder if the skill sets for both of those type of liaisons, whether they were with the Hispanic population or the Hmong, were those skill sets similar? And in what ways, do you work on those, or do you help them develop that, or do they already come with it?
Well, I mean, some of it is they're already connected in the community, or that they are really wanting to help their communities. And one of the things that our new grant will enable us to do too is that we want to do more of a intentional education for them, in the sense of not just around COVID, but about influenza vaccines. How do you deal with people that basically are naysayers to vaccines, or like have a completely different view of things? Information about like health literacy, the open enrollment piece in terms of connecting people with whatever benefits they have. And so as we kind of gradually keep trying to build their toolkit, I think that they'll better be able to, not that they can do everything themselves, but at least know where to send people for that help.
Yeah. Okay. I don't know if you see the same indicator on your screen, but we've got approximately 1 minute and 30 seconds remaining before we will be automatically shot back into the main room. If there are any other questions right here, I have a few other compliments that are, written in the chat, and congratulating you on your presentation and on your work. Outstanding. I thought everyone, it's really nice for me as somebody that works predominantly in education to hear, this side of things was excellent. And it was a great way to spend my afternoon. So I appreciate all of you and all your work. So thanks very much.
Thank you.